acute lymphoblastic leukemia. Don't write it as lymphocytic leukemia. Acute means always blast, immature. Oh my God, exam. So there is an FAB classification for ALL. Supposing in the exam they ask you just FAB classification, you will have to write classification for myeloid leukemia as well as classification for lymphoblastic leukemia. Let us see this first. There are three types of ALL, L1, L2, L3. So in this one, there will be small uniform cells, whereas in this, there will be large uniform cells, homogeneous. Whereas in L2, it will be a mixture of small and large. Percentage, we need not remember. The nucleus is round, regular, and it can be slightly variable, whereas it is large in a case of L3. Nuclear cytoplasmic ratio is high in all. But what happens is nucleoli will be inconspicuous, hardly 1 to 2, difficult to see. Look at this particular picture, compare it with the earlier AML. There are some nucleoli which is difficult for the student to identify. There can be some kind of a bend or a hitch that is seen in the nuclear margin. But hardly any cytoplasm, increased NC ratio. RBCs are normocytic, normochromic, platelets are reduced. And there's a WHO classification. There can be the B cell, T cell, and the Burkitt's lymphoma counterpart. Three things you people will have to remember by heart. And this is the blood picture. Obviously, you people will have to by heart these. The clinical features I mentioned it. Usually ALL occurs in children. So that can be a history for us in the chart or the exam. And the duration is always short for an acute leukemia. These will be the clinical features. Blood picture, generally, there will be an anemia, hemoglobin will be reduced, standard for all leukemias. But in a case of WBC, the count is increased, though not as much as AML. It starts from 20,000, but can go up to more than 1 lakh. The cell is the lymphoblast. You will have to describe that particular table. And look at this one. The cells are large. Even the small cell is larger than the RBC. Here I am finding a mixture of small and large. And it has got a large NC ratio. Nucleoli not very conspicuous, 0 to 1 or 1 to 2. And when the count is reduced, it is called a subleukemic leukemia. We will be taking a Buffy code for the diagnosis or do a bone marrow. Serum uric acid is increased because of increased turnover. And chemotherapy also will cause destruction and increase. LDH is increased. So this is one. A differential diagnosis we must be having in mind will be the bone marrow. You will have to see the cellularity, erythropoiesis, leukopoiesis, megakaryopoiesis, and the blast cells. That I have mentioned already. The differential diagnosis can be because of lymphadenitis. Sometimes AML, you will have difficulty in distinguishing leukemic phase of a lymphoma. Patient is having a lymphoma which is spilling over into the peripheral blood. And metastatic tumors such as small round cell tumors can mimic the ALL. Other investigations can be these: phenotyping, cytogenetics, X-ray. You look for any mediastinal widening. CSF for leukemic cells. Treatment is chemotherapy, and CNS, there can be a cranial irradiation. You'll have to maintain a supportive chemotherapy, and you'll have to also monitor the platelet count. That comes to the end of class number 23. I would like you people to mug up each and every word from my book, 1 page. Thank you.